So one of the already accomplished feats of immunotherapy has been the prophylactic vaccination against HPV as a cause for cervical cancer. And so we're fortunate to have with us a leader in studying the clinical immunology of HPV disease, Dr. Connie Trimble from Johns Hopkins.
Good afternoon, and thanks in advance for your attention. It's an exciting program. I'm feeling surrounded by solutions, and what I'm about to show you for the next 25 minutes is one problem after another. We study immune-based therapies for pre-invasive HPV disease, and the Immunology 101 list of requirements is deceptively simple. Identify a disease-specific antigenic target, make an immune response. Okay, make an immune response that traffics to the site of disease. Oh, right. Make an immune response that traffics to the site of disease and is functional at the site. The big picture from 40,000 feet is that probably 1 in 5 human cancers is caused in the context of a persistent infectious pathogen that has a specific tissue tropism. This chart, Doug Lowy made this chart, and it hasn't changed very much in the last several decades. But it shows you depicts the magnitude of disease caused by infectious pathogens. Of the viruses, HPV causes more cancers than any other virus globally. I have cervical cancer listed here, but we have very cumbersome, but in the right setting, effective screening technologies available to identify pre-invasive disease for cervical cancer. But knowing a lot about the immunobiology is not always enough to translate into preventing or treating human disease. And cervical cancer, despite the fact that we have known how to screen for it for over half a century, is still the second leading cause of cancer death in women worldwide. We have preventive vaccines available for 2 of the pathogens that cause a lot of cancer. But for many reasons, I don't think anybody in this room is going to go out of business. This is, unfortunately, this is a slide depicting the incidence of disease in the United States. And although for various reasons, I think I encounter a lot of people who seem to think that because the preventive vaccines are now available, that HPV disease is a done deal. In fact, it's not. And the incidence of HPV-associated disease at other anatomic sites for which we have no screening algorithms is increasing fairly drastically. The most drastic disease site is disease of the head and neck. If you look at the incidence curves in the United States, the incidence of HPV-associated cancers of the head and neck is going to cross the incidence curve for HPV disease of the cervix. There's a lot to be learned about the immunobiology of the oropharynx as opposed to the genital tract. For some reason, the preponderance of disease of the oropharynx is in heterosexual, immune-competent males in their 4th and 5th decades of life. I say this always when I'm in front of industry people. For those of you who are not parents or clinicians, I made this slide. Essentially, everyone who's been sexually active has been exposed to HPV. You get it as soon as you start having sex. It's completely asymptomatic, and most people clear without ever knowing that they were infected. And so the lifetime risk of being infected at least once with an oncogenic HPV genotype is thought to be well over 80%. This is data from the CDC depicting self-reporting in American boys and girls who are reporting the onset of penetrative heterosexual sex. For those of you who are squinting, by age 19, 3/4 of young people have had sex, at least once. And the other piece of information here, which is interesting, is that boys and girls track right together. So it's not as if there's underreporting or overreporting, we think, by one gender or another. You betcha. The issue with the vaccination is that uptake in the United States is really appalling. In the United States, uptake of the preventive vaccine, which has no therapeutic effect, is in eligible cohorts is less than 50%. This number is decreasing, according to very recent data. The vaccination sequence involves 3 vaccinations over a series of 6 months. And you'd think that amongst people who had initiated the series, that they would consider it a good. But in fact, rates of vaccine completion amongst vaccine initiators is less than 1 in 4. So from a public health policy, that's a very expensive way to spend your public nickel, because these people will obviously need to continue to be screened. We spend $6 billion a year per birth cohort in screening for just cervical disease alone. This is a mantra of how a cervical person thinks about HPV infection. Normal cervix, everybody gets it. The top frame here is a cytopathology slide of normal. The middle frame is a low-power H&E of a normal cervix, stratified squamous epithelium, and on the bottom frame is what a normal cervix looks like. In the case of a persistent HPV infection, the relevant biological event is that the viral genome inserts into the host genome, and you have subsequent functionally requisite expression of 2 viral proteins, E6 and E7. Expression of both of these proteins is required both for disease initiation as well as persistence, and that's why we target our adaptive adaptive T-cell therapies towards these antigens. So there's a true, okay, so requirement number 1, we've figured out, we think, a relevant tumor-specific antigen. These 3 panels depict what we see in persistent high-grade lesions. The top is a pap smear, so we could screen for this disease long before we knew what the cause was. You see they look dark. There's a high NC ratio. The middle panel is what a typical histology looks like, and it turns out to screen, you can actually just look at the thing. What we do is a procedure called colposcopy, in which we just squirt a dilute vinegar solution on the cervix, put on a green filter, and look. And cells with a high NC ratio are more susceptible to, basically, they lose water. And so they become opaque, whereas a normal cell with a itty-bitty nucleus and a lot of glycogen is not going to be affected nearly as much by the vinegar. We think that all invasive squamous cancers arise from untreated high-grade lesions. This transformation from normal cervix to persistent HPV infection to a high-grade lesion to invasive cancer transpires over a very long time. It takes at least 10 years, we think. And so from a public health perspective, there are many opportunities to identify and prevent disease. The target of screening for most strategies is the identification of SYN3. While all invasive cancers are thought to arise from untreated SYN3s, we've found that not all SYN3s turn into cancer. This is a schematic of an observational cohort that we've had open at Hopkins for 10 years. Almost 400 people have entered in it, and they have provided really very interesting insights, as well as many, many tissue specimens. We have over 14,000 now tissue specimens collected longitudinally on these patients that are very closely clinically characterized. And we find that even amongst patients with HPV-16 associated disease, that 25% of these are gone at week 15. This is my only version of a Rosengram, which several people have shown you today, but here's a high-grade lesion in colposcopy, one of my early unvaccinated patients. The lesion is right here. The rule was Trimble can't cure the patient by biopsying it off. The patients have to have residual visible lesion. And 6 weeks later, when she came in, it was gone. Now, remember I told you that the viral genome has integrated in these high-grade lesions. So really, the only way that this could happen is if somebody's T cells got smart. So we chose this patient population to study because we thought they could be potentially informative. In the meantime, my collaborators, T.C. Wu and Drew Pardall, had developed a therapeutic vaccine. This is a DNA vaccine, and it cured bulky tumors in black 6 mice that had E7-expressing epithelial tumors. And so I kept these slides small. This is the only preclinical data I'm going to show you, but of course it's the kind of data that generates a clinical trial. This plasmid generates huge ELISpot responses in the black 6 model and has both preventive and therapeutic effect. Off we go. This was our first clinical trial. It was a standard dose escalation trial testing this plasmid in patients with HPV-16-associated pre-invasive disease. The schema's on the top. I left the observational cohort on the bottom for your reference. What did we find out? Well, unfortunately, the rate of regression in the highest dose cohort was exactly the same as in our unvaccinated patients. We thought we'd look in the blood to see if we had elicited immune responses, and I'm not even going to show you that graph because it's so sad. In any case, the elephant in the room. I have 2 slides of this, and I don't want you to squint. But the point of these slides, these are summary slides depicting every single clinical trial that very careful and thoughtful translation groups have carried out with investigator-initiated INDs, testing different kinds of therapeutic vaccines for pre-invasive HPV disease. By and large, and they failed by 2 standard metrics of success. They made very small peripheral blood T cell responses. I'll read these for you because I, on purpose, don't think you can read, maybe. But 10 spots per 1,000,000 PBMC, it's hard to imagine that could cure disease. The other issue is that these T cells had to be manipulated pretty extensively ex vivo to be able to find a detectable response. Here's a whole nother page of them, including ours. And I think it's safe to say that until relatively recently, the field of therapeutic vaccination for HPV disease probably elicited more skepticism than T cells until these 2 studies were published. Now then, these 2 studies were published testing therapeutic vaccination for patients with vulvar intraepithelial neoplasia. And the reason that I highlight this distinction is because VIN, unlike cervical disease, is clinically very, very recalcitrant. It never goes away. Maybe less than 1% of lesions go away on their own. And these 2 groups got a huge complete response, complete regression rate, 47% in the case of the group from the Netherlands, and almost 2/3 of the patients in the group from Manchester. So this is not by accident, and I will point out that both of these groups had really maybe modest T cell responses to vaccine antigens. In sympathy, Li Ping Chen gave me this slide. So the conclusion, the logical conclusion from these data is either that we are targeting antigens that are irrelevant, or we could be actually just looking for them in the wrong place. So what we study now is what's going on in the tissue. And in patients who have completely negligible peripheral blood T cell responses to HPV antigens, we see this in the tissues. And you don't have to be a pathologist to see where the party is. This is a resection specimen of a patient with a persistent lesion at week 15, persistent CIN3, and immediately adjacent normal mucosa. What we did notice was that even though immune cell infiltrates and persistent CIN2-3 were really localized to the dysplastic tissue, in persistent lesions, they didn't get in. I mean, it was as if they got right there and then were total stoners. And here you can see a CD8 immunostain in the same section. The day I met Bob Schreiber, he looked at that and he said, "Oh, wow, the T cells are keeping the lesion in. And I said, no, Bob, the lesion is keeping the T cells out. And actually, at this point, I don't know which is which still. And I'm sure there's a quant in this room who can help us figure that out. In any case, we were such T-cell chauvinists, we realized that we should actually look into whether T-cells were actually involved in clearing a lesion. So we went back to our unvaccinated cohort, looked in the tissue at time of entry. This is a CD8 immuno on a patient whose lesion subsequently regressed. Indeed, you can see CD8 T-cells in the epithelial compartment. Whereas this is a biopsy of a patient whose lesion was persistent at week 15, and you can see that her T cells are limited pretty much to the stromal compartment. We have since developed some computer image analysis algorithms, so it's not a matter of Trimble sitting in the dark and counting these doggone things, but it's predictive. These data forced us to re-examine our understanding of how immunosurveillance takes place. I'm a clinician by training. I thought that this business of a T cell zooming around, encountering antigen, getting activated, doing its job, and then zooming around was not totally efficient for responding to an infection, to a subsequent infection. What we learned in medical school was that tissue-homing T cells, even if they did exist, were in the blood or in peripheral lymph nodes until recruited to where they needed to be, and that there were very few T cells in normal tissue. But if you turn this around on its head, if the button works, oh. Okay. And posit a separate population of tissue-resident T cells compared to peripheral blood, what would you expect to see in your patients? Well, in the peripheral blood, you'd see both naive and memory cells, whereas in tissue-resident cells, you'd expect to see mostly antigen-experienced cells. I don't know what to call them anymore. In the T-cell receptor diversity in the peripheral blood, you'd expect to see more or less a Gaussian distribution, whereas in tissue-resident populations, you'd expect to see clonally expanded populations that are probably driven by tissue-specific organisms. This next group I used to call memory cells, and now I don't know what to call them at all. But in the blood, we see CCR7 positive cells. In the tissue resident, they have more of an effector memory phenotype and are slightly activated. The intraepithelial cells express CD103, are mostly CD8 T cells, and express tissue-specific homing integrins. In the peripheral blood, T cells have more or less a resting phenotype, whereas in tissue-resident populations, we find that they're slightly activated and express not only CD69, but also CD25 and to some extent actually PD1 in normal tissue. Here's an immunostain of CD8 in perfectly, completely normal cervical mucosa. The CD8 T cells are exactly where you'd expect them to be at the basement membrane. What we try to do now is to figure out what the rules are in what's essentially a non-sterile barrier epithelia, which is where a lot of your body's T cells live. This makes a lot of sense here because this is a non-sterile microenvironment, if you will, and there's a lot of commensals, and you don't want your tissue-resident T cells to be firing off sort of indiscriminately every time it sees somebody. But on the other hand, if a pathogen actually does penetrate through the full thickness of the squamous epithelium, that's actually when you want somebody to fire off. So the goal now is I think the holy grail for preventive and therapeutic vaccines is to be able to elicit a T cell response that's specific for antigen that will traffic to perfectly normal tissue of interest and established resident. That's a very tall order. One of the first problems we wanted to address was why the T cells didn't get in. A very common mechanism by which established invasive tumors evade an immune response is by generating neovasculature that doesn't express adhesion molecules. Now, when we do a colposcopy to evaluate an abnormal pap smear, not only do we look for the white epithelium, but we also look for a very specific pattern of neovasculature called mosaicism. And if you can see it here, it's this thing that looks like the top of a manhole. We thought that cervical tissue-resident T cells would express skin-homing integrins because it's squamous mucosa. It looks like squamous epithelium. None of the T cells, either in normal cervix or in persistent dysplasia, expressed skin-homing integrins, CLA and CCR4. What was supposed to be our negative tissue control turned into a Bubba Gump moment. And it turns out that nearly all of the T cells in both normal cervix as well as in persistent dysplastic cervix express what we thought of as GI homing integrins, alpha-4 beta-7. So we looked for the expression of the ligand of alpha-4 beta-7 on these vessels, and the intensity of CD8 infiltrates correlates pretty directly with the intensity of MADCAM expression. This is a lesion that permitted CD8 infiltrates into the epithelial compartment and the corresponding distribution of MADCAM expression. And here's a lesion that didn't permit CD8 infiltrates, and the expression of MADCAM, you can see, correlates pretty darn directly. And the R squared is 0.8 in the if you look just at the diseased epithelium, it's closer to 0.9. What it suggests is that therapeutic strategies should include ways to activate lesional vascular endothelium. So the next trial, which is ongoing now, is we're employing strategies to make not only a bigger immune response, but also trying to tell it where to go. I've put the expected rate of regression in unvaccinated SIN2/3s for your reference here in this time frame. Our patients get 2 priming vaccinations with a DNA vaccine and a boost vaccination with a recombinant vaccinia construct. The first 3 dose cohorts, the patients are getting successively higher doses of the vaccinia. We're starting to see responses. The way we actually try to get the T cells into the lesion is just by applying a topical TLR agonist, imiquimod. This is a reagent that's commercially available for first-line therapy for external HPV disease. We also use it for actinic keratoses and early basal cell carcinomas. We apply it just 3 times. It's a really homeopathic dose. The rate of regression in HPV-16 infected lesions is about the same as in unvaccinated patients. We have a very unusual patient cohort where we are, people come and they tell me, I want to be screened for, I looked you up on clinicaltrials.gov and I would like to be screened for eligibility for participation in this trial in this cohort. And I sit there and I think, okay. Anyway, so only half of high-grade lesions are caused by HPV-16. We opened up a cohort for patients who are not 16 positive. The rate of regression to date in that cohort is 75%, so we're obviously going to have to expand that cohort. But imagine if you had a high-grade lesion diagnosed and there was a 50-50 shot chance that you had a non-16 associated lesion. If you could have a special sauce and not a surgery, that would be pretty darn exciting. Of course, we have a challenge of trying to figure out what's going on in these patients because ethically at week 15, if they've gone HPV negative, tissue negative, I'm not going to do a resection. And so we have many, many brushes banked, and we'd like to figure out longitudinally on these subjects, and we'd like to be able to figure out what's going on in these patients. The last dose cohort is going to get the highest dose of vaccination as well as imiquimod. And so by conventional measures of success, I will tell you that the ELISpot responses are minimal to modest, and we censor these responses at week 15. It's not exactly like the Bruins game, but it is a time shot. And so by those 2 criteria, not success. Well, it's probably not as binary, and our question is really, can we detect measures of effect as opposed to complete efficacy that would allow us to design a more intelligent trial? Can systemic vaccination boost tissue T cells? So I'll show you some data from, here's a cartoon of the prime boost trial from tissue, from the diagnostic biopsy, and from the same patients from post-vaccination at the time of their resection. We think we do see a response in these patients. This is a patient's biopsy before vaccinations. I've marked out epithelium and stroma, CD8 infiltrates, after. These cells are polarized in a way that is likely to be useful. This is Tibet, before, after. We had a come to Jesus moment. We stained for Ki67. The lesion itself is a nice internal control because it's proliferating. Before, after. The reasons that a stromally located immune cell would turn on Ki67 have to do with really engagement via an activation through the TCR. We see also changes in where the T cells go. Here's a low-power H&E of a patient before vaccination, after. I want to draw your attention to the fact that not only are there more intense infiltrates in the lesional tissue, but they're sort of organized into what Wolf Friedman would call tertiary lymphoid structures. I'll show you a higher power mag of the lesion here. You've seen that. Yeah, she showed me that a couple of times. Here's a higher power mag of the small amount of residual lesion here. I want to draw your attention to several differences. First of all, the vasculature is really different from in the pre-vaccination specimen. The endothelial cells are almost cuboidal and hopped up and activated. There's a lot of them. These stain with PNAT. They look just like HEVs. In addition, these immune cells are getting into the lesional epithelium, and this is what an apoptotic cell looks like. It's very difficult to isolate T cells as well as other subsets from these small tissue explants. So we've been very leery of going down that road until we had enough indirect evidence of success. And I'll just show you one more piece of this story here. This is a resection from a vaccinated patient, perfectly normal epithelium on top. What's that stuff right there? Looks like a germinal center. It's a higher mag. Maybe some of you who are pathologists can see that this white blob is different from that white blob. In fact, what this is it's the tip of a gland that's dived down, that's not in this plane of section, and there's a nest of residual dysplastic epithelium at the tip of the gland, and this guy right next to it is a germinal center, which has clearly decided to set up shop just there. Based on this kind of evidence, we decided to see if we could detect evidence of function. We microdissected normal and epithelium and stroma from normal cervical mucosa, from unvaccinated dysplastic mucosa, and from a subset of these patients with what we started calling the tonsil sign, because there's such intense inflammatory infiltrates. And we did find evidence, transcripts associated with immune recruitment and activation in the stroma, which was nice. But to our surprise, we also found evidence of immune activation in the epithelial compartments overlying these structures, which prompted us to go down even farther. It's very tempting to speculate at this point that these T cells could actually be virus-specific. As I said, it's very difficult to get at specificity. We think that T cells that have committed to being tissue-resident T cells, it's very difficult to understand, get a grip on what their specificity and function is. You can't just pull them out. We think that they need something in the tissue at that point to function. So it's difficult actually to actually pull TILs out and then incubate them with APCs or whatever magic of choice and actually get them to make gamma, or let alone determine whether they're polyclonal. So we were going backwards, and I'll show you some, we're going to get a little bit like lab meeting here, but this is new data showing TCR sequence analyses. So this is a low-power H&E of an unvaccinated persistent HPV-16 SYN3. On the left, on the y-axis, are expanded tissue-specific clones in this patient and her and peripheral blood from the same patient. So we do see some shared T-cell receptors between the two compartments. The distribution seems to be different. Another way to look at that information is we chose the top 20 overexpressed TCRs in the tissue and looked at their frequencies in the blood. It doesn't look as if they're just leakage. And this is another way to look at the frequencies. So clonally expanded TCRs in the tissue can also be identified in the blood. So in theory, we can go backwards now. This is that patient I showed you with the T cells getting into her residual lesion. Kind of the same thing. Okay, that's interesting, and here's the same data. And it's still a little bit like throwing a ball of mud at the wall, unfortunately, and seeing what sticks. And what we really want to get at is whether these cells are virus-specific. It turned out that two of the patients, the vaccinated patients with these germinal centers in their residual lesion, shared 2 out of 3 class 1 alleles and 3 out of 5 class 2 alleles. So we thought, well, what the heck? We'll see if they have shared clones between the tissue. In fact, they did. Boom, fell out just like that. And so now it may be possible, we think, to be able to go backwards. We know the V-beta families of these shared TCRs, so it could be possible actually to try to figure out what epitopes they're seeing. We can expand using anti-V-beta antibodies and anti-CD3 in much the same way Carl showed you. He can pull out T cells using anti-CD3, anti-CD28, and see if they're actually specific for HPV antigens. This is not an Andy Warhol image, but for those of you in this room who are interested in quantitative image analysis, please come find me. The idea we want to pursue also is to be able to do really targeted analyses of these immune cell populations, not just a chunk of tumor, whether it's viable or not, compared to chunk of normal. It's probably very important to microdissect out as much as we can where they are and their relationships to each other. So one of our colleagues has developed a method of doing 7-color immunofluorescence on formalin-fixed tissue. It's essentially and doing computer digital image analysis, and it's almost like doing flow on tissue specimens. And the advantage of doing it this way is that what we want is for these strategies to be accessible to any surgical pathology laboratory so that they can be used, adapted, and used widely, both to identify predictors of response as well as hopefully to monitor responses, not only to immunotherapies, but also to other conventional anti-cancer treatment modalities. We've started to do this on cervical tissue, and we'll be doing a Th1 and also probably a myeloid suppressor cell signature on these things. We're really T-cell chauvinists. It's important not to focus just on our cell of choice, and we've started also isolating out other cells, subsets from these tissues. It turns out, maybe not surprisingly, that we find activated fibroblasts in the stroma. It's not just reactive, they're actually perverted and helping to drive the show, we think, but now we can isolate them from the fresh tissue explants from the resection. We have passage 1 fibroblasts. They're about as unmanipulated as we're going to get, and our goal now is to study the stromal cell subsets, including macrophages and fibroblasts. We do see, much like the gastric dysplasia data, we see methylation changes in the fibroblasts of even pre-invasive disease. And these, in the gastric models at least, precede the development of overt dysplasia in overlying epithelium. And so we think there's potentially another therapeutic target that we can manipulate in concert with the immune therapies. Not such an easy problem. Identify a disease-specific antigen target. Okay. Make an immune response. Okay. Make an immune response that traffics to the site of disease. Okay. And make one that's functional, whether it's effector or suppressive. We have taken this backwards way of thinking about immune cells and managed to convince the Keystone Symposia to do a new conference, which will happen in January of 2014. The program will bring together people studying immune T-cell responses in a tissue-specific way, namely people studying infectious disease, autoimmunity, and tumor immunology. And we hope that you may be interested enough to join us in Snowbird. That's the view from 40,000 feet. I'd be happy to, oh, no questions. Okay, talk to you in the lobby, I guess. Thank you for your attention.